Guidance started really, really small. It was, 3 people in a little overheated room in the top floor of the hospital trying to kind of build something from a need. And yes, it's, a software application and there are lots of those around, but it really was built because there was an actual problem.
A lot of the stuff that we did with guidance was really at the forefront or pioneering antimicrobial stewardship. Every day in Australia, probably 40% of patients are on an antimicrobial in the hospital. Systems like guidance can actually not only identify who these patients are, but they support the team to review that prescription, work with the clinical team, offer opportunities to change or improve their prescribing quality.
I know at many hospitals, when they implemented approval systems, it was a phone-based system. The downside of that is that it was very labour intensive. The physicians could be getting 20, 30, 40 phone calls during the day, which was quite disruptive to their workflow.
As we were starting to demonstrate that this thing was working and we thought we were onto something good and we're presenting it at conferences and to our peers and colleagues, they became interested, and it was Peter McCallum who took it on. They were the next site. Being able to demonstrate transferability was a really big thing for us because we knew there were other products that bespoke things that people were building in their own hospitals that had failed when people tried to transfer them. So they were very much reliant on a single enthusiast keeping them going, and they really hadn't been built with that discipline around it in terms of being able to pick up the product and have it work somewhere else.
So what we do is ensure that the approval process meets best practice. So we map all our antimicrobials and indications to the national guidelines, and we provide access to those national guidelines at the point of care. So if they're choosing a particular drug and indication, they can immediately see what the actual national recommendations are. There might be some local modification of that, which it can deal with. It's a very flexible program. So in fact, sites could choose how they would implement it, which drugs would be in it, what sort of guidelines, how they'd run their restrictions. Some sites were amazing because they would implement it as a network. So Stuart Bond and his team and Pam Kenichi and the team in Sydney published on their success of guidance driving their stewardship program in a network of hospitals, and were able to demonstrate that there were not only improved use of antimicrobials, but there was less Clostridium difficile infections and also improved mortality for common infections. So that's, for us, was an incredible affirmation of what we thought you could do if you had the right data to demonstrate the impact of your program. And that's the ultimate goal, isn't it? That you're able to improve patient care at that level.
Kaz and Kirsty were such pioneers in this area. They'd really been involved in, all the national working groups and technical advisory committees, and they've been heavily involved in setting the national strategy and agenda on stewardship to drive home just how important stewardship is. It totally, completely changed the landscape across every single hospital in Australia, public and private.
The impact that they're having, it's beyond what an individual hospital does. It moves to how things are now done. If you look at what used to happen 15 years ago and opposed to what happens now, they have driven in Australia that change.
The National Antimicrobial Prescribing Survey grew out of the guidance group, and that has been used nationally in aged care, in Canada, Bhutan, Malaysia, New Zealand. That's amazing, and that would never have been possible without a core group of clinicians, including ID physicians, microbiologists, pharmacists, and our developers, and our collaborations with all sorts of people in the precinct, particularly in the Doherty, to be able to do that.
It's a different world that we're working in at the moment now, because there are lots of people fiddling with their electronic medical records and trying to do things that partially do what guidance do, and they're getting so far with it, but it's not meeting the vision of what we can see that the redevelopment of guidance can deliver.
There's legions of evidence to show that appropriateness of prescribing is not necessarily improved by these systems at all. So you do need stewardship systems to support improvement.